glaucoma. Coming to the anatomy of glaucoma. Anatomy. Now the angle structures from behind forward is root of iris. Then we can see the ciliary body band, anteriormost part of ciliary body, that is ciliary band, ciliary body band, scleral spur, trabecular meshwork and Schwalbe's line. Now this is the structure. The gonioscopy is examination of angle of anterior chamber with gonio lens. This is the gonioscopic view. Here we can see the iris root, then ciliary body band, trabecular meshwork and Schwalbe's line. Now coming to gonioscopic grading using Schaffer's grading. Schaffer's grading of anterior chamber angle. Here it is divided into 4 grades, grade 1, 2, 3, 4. So in grade 1, this is grade 0 is angle is closed, that is no angular structures are visible here. Grade 1 it is less than, angle width is less than 10 degree. There is high risk of closure here, there is high risk and it is extremely narrow, only Schwalbe's line is visible. Grade 2 was 20 degree angle width, that is narrow, both Schwalbe's line and anterior trabecular meshwork will be seen. In grade 3 it is 20 to 35 degree, it is open angle, Schwalbe's line, trabecular meshwork and scleral spur will be seen. In grade 4 35 to 45 degree wide open, Schwalbe's line, trabecular meshwork, scleral spur and ciliary body band. Like in grade 4 all 4 structures can be seen. In grade 3 3 structures, 2 structures, 1 structure, like that you can remember. This is the Schaffer's grading. Grade 1 10, then grade 2 20, then grade 3 30, like that. Only the based on the angle width it is divided. Based on this we can grade it as like there is based on this the angle closure risk can be graded, like grade 1 have high risk of angle closure, grade 2 has grade 1 has high risk of angle closure, grade 2 possible risk of angle closure, grade 3 and 4 is wide open, there is a angle closure is impossible in grade 3 and grade 4. To differentiate between primary open angle and primary angle closure glaucoma, we can use gonioscopy to view the anterior chamber angle. These are the structures in the anterior chamber angle from behind forward. Coming to next is aqueous outflow system. Aqueous outflow system. Now there is first we will talk about trabecular meshwork. This here is a trabecular meshwork. Then it goes to Schlem's canal, then collector channel. First one we will talk about trabecular meshwork. It is a sieve-like structure through which the aqueous leaves the eye. It consists of 3 layers: the uveal meshwork, corneoscleral meshwork and the juxtacanalicular meshwork. Uveoscleral meshwork, this is a uveoscleral meshwork here. Uveal scleral meshwork. It is the innermost part. It extends from the iris root. It extends from the iris root and ciliary body to the Schwalbe's line. Then the arrangement of uveal trabecular bands create opening of about 25 to 75 micrometers. 25 to 75 micrometers opening, and it extends from iris root ciliary body band to Schwalbe's line. Next is corneoscleral meshwork. This is a corneoscleral meshwork here. The corneoscleral meshwork. It is a middle part and extends from scleral spur to the lateral wall of scleral sulcus. Scleral spur to lateral wall of scleral sulcus. Now the sheets of trabecular perforated by elliptical opening of, these are the elliptical opening of 5 micrometers to 50 micrometers. It is the size of the pores. Next is juxtacanalicular meshwork. This narrow part connects the corneoscleral. It connects the corneoscleral here. This is juxtacanalicular meshwork. It connects the corneoscleral with the Schlem's canal. This part mainly offers normal resistance to outflow. Okay. Then next is Schlem's canal. Schlem's canal, it is an endothelium blind channel. Here this is a Schlem's canal. It is an endothelium blind channel, and it drains aqueous humor from anterior chamber of the eye into the anterior ciliary vein. Okay, that is the Schlem's canal. Next is collector channel or intrascleral plexus. Collector channel or intrascleral aqueous vessels. That is, it leaves the Schlem's canal to terminate in the episcleral vein. See here, this is the trabecular meshwork, then scleral spur, this is scleral spur here, then trabecular meshwork, Schlemm's canal drains into collector channel, which drains into the aqueous vessels, then further to the episcleral plexus. Now this collector channel, there can be a direct system or indirect system. See, this is the direct system. The direct system directly went to the episcleral veins. See, from Schlemm's canal directly into the episcleral vein. It directly go to the episcleral vein. That is a direct system. Direct or indirect is like it can form an intrascleral venous plexus. From Schlemm's canal through an intrascleral venous plexus, it goes to the episcleral vein. Then it is known as indirect system. Next, coming to aqueous humor. Aqueous humor, the volume in anterior chamber is 0.25 ml. Volume in posterior chamber is 0.06 ml, and refractive index of aqueous humor is 1.336. Functions of aqueous humor is maintenance proper IOP, maintenance of IOP, then important metabolic role by providing substrates and removing metabolites from the avascular cornea and lens. It provides metabolism and it removes the metabolites and provides substrates like antioxidant like that, and to the cornea and lens, and helps in maintaining the optical transparency. It takes the place of limb that is absent within the eyeball. Okay. Now composition of aqueous humor. It is composed of water 99.1%, 99.9% is composed of water and solid 0.1%. Now the protein is the colloid content. Colloid content consists of 5 to 16 milligram percentage. The composition is similar to plasma. Aqueous humor composition is similar to plasma, except that it contains it has high concentration of high concentration of bicarbonate, ascorbate, pyruvate, lactic acid, and decreased concentration of protein, urea and glucose compared to that of plasma. Other than that, everything is similar to plasma. High concentration of bicarbonate, ascorbate, that is antioxidant, pyruvate, lactic acid, and decreased concentration of protein, urea and glucose as compared to plasma. Now posterior chamber has higher concentration of bicarbonate and ascorbate than anterior chamber aqueous, and posterior chamber aqueous has lower concentration of chloride than anterior chamber aqueous. Coming to production of aqueous humor, normal rate of production is 2.3 microliters per minute, normal rate. Now steps in production are ultrafiltrations. Steps are ultrafiltration, secretion and diffusion. Then drainage of aqueous humor. It can be either by trabecular, that is a conventional outflow, or avascular unconventional outflow. Now trabecular meshwork. From trabecular meshwork, it goes to the Schlemm's canal and then to the collector channel. From trabecular meshwork, it goes to the Schlemm's canal and then to the collector channel. It is a main outlet. It is a main outlet for aqueous from anterior chamber, and 70 to 80% of the aqueous is drained via this route. Then the avascular or unconventional, it constitutes about 20 to 30% of the aqueous drainage from ciliary body band to the suprachoroidal space to the venous circulation of the ciliary body, choroid and sclera. That is the aqueous outflow, drainage of aqueous. Now coming to maintenance of IOP, normal IOP is in the range of 10 to 21 millimeters of mercury. That is mean is 16.5 plus or minus 2.5. That is the main IOP. Now IOP is higher in the morning, it is increased in the morning and decreased in late evening. Normal eyes have a smaller fluctuation, that is less than 5 millimeters of mercury. If there is more than 8 millimeter fluctuation, then it is confirming glaucomatous eye usually have fluctuation of more than 8 millimeter mercury, known as a down eye sign. Now IOP increases from changing from sitting to supine position. Sitting to supine also IOP can change, and also blood pressure does not have any effect on long term IOP. Then increase in plasma osmolarity. Decreases in IOP. Results in a fall in IOP, increase in plasma osmolarity. Now coming to the first conditions, diseases. First is primary developmental or congenital glaucoma. It is a newborn glaucoma or true congenital glaucoma seen in 25% of cases when the IOP is raised during intrauterine life and the child is born with a congenital ocular enlargement. That is newborn glaucoma. It is called as that is congenital glaucoma. Primary development is in the when the child is having high IOP in the intrauterine life. Infantile glaucoma is when the disease manifests within third year. Then juvenile glaucoma is between 3 to 16 years. Usually infantile is like before 1 year, but here we consider it as by third year, and juvenile is 3 to 16 years. Then incidence is 1 in 10,000 childbirth. Boys are more commonly affected. When the disease manifests before 3 years, the eyeball enlarges. That is known as ophthalmos. That is bull-like eyes. As a result, due to retention of aqueous, it can also be known as, it is also called as hydrophthalmos. Most cases are sporadic in occurrence, that is 90% cases are sporadic, 10% cases are autosomal recessive. Mutation is in the, if there is mutation in the CYP1B1 gene, then they gives a risk factor. Okay. Now pathogenesis of primary developmental or congenital glaucoma. It is presence of cellular, if there is a presence of a cellular membrane which there is here in the trabecular outflow, if there is a cellular membrane that is known as a Burkitt's membrane, it obstructs the outflow. Now maldevelopment of the trabeculum, that is known as trabecular dysgenesis, including this trabeculum is including the iridotrabecular junction is responsible for impaired aqueous outflow and increased IOP. Maldevelopment, okay, leading to trabecular dysgenesis. That is also a pathogenesis. Next pathogenesis is trabecular dysgenesis. This trabecular dysgenesis is characterized by flat iris. See, this is iris, it will lose its convexity and then there is flat iris or it is anterior to the scleral spur, so that it will impair the obstruction. This is scleral spur, it is anterior to the scleral spur. Trabecular dysgenesis is characterized by flat iris insertion, concave insertion, iris sweeps into the iridotrabecular angle. Here iris sweeps into the iridotrabecular angle. Now there is in trabecular dysgenesis there is absence of angle recess. Okay, angle recess is usually seen in trauma. Trabecular, it is characterized by flat iris insertion and concave iris insertion, as concave is the iris sweeps into the iridotrabecular junction. Okay. Now clinical feature, congenital glaucoma is characterized by photophobia, blepharospasm and lacrimation. These are the classical 3 symptoms. Photophobia, blepharospasm and lacrimation. There will be history of rubbing of eyes. Corneal signs will include corneal edema, that is a first sign. Okay, corneal edema is the first sign, that is there will be hazy cornea. Then corneal enlargement will be there and descendant membrane breaks known as a Harp striae will be seen. These breaks in the descendant membrane is known as Harp striae due to stretching. Horizontal is seen in H4H, horizontal, you remember, this is horizontal, H4H. Horizontal breaks, corneal enlargement will be seen. Then newborn, normal infant cornea measures about normal, it is 10.5 mm. 0.13 confirms enlargement. More than 13 mm confirms enlargement and more than 16 mm is poor prognosis. Corneal scarring and vascularization can be seen in advanced cases. Now a deep anterior chamber will be seen, there will be deep AC, then axial myopia will be there, then sclera becomes thin and appears blue. Okay, then flat lens, optic disc cupping and later atrophy will be seen. Deep anterior chamber and axial myopia, remember. Now treatment is primary surgical treatment. That is incisional angle surgery, goniotomy and trabeculotomy can be done. Goniotomy is the internal approach and trabeculotomy external approach. Filtration surgeries, combine trabeculotomy and trabeculotomy with antimetabolites can be, that is a standard procedure. Then glaucoma drainage device for incalcitrant cases. Next is glaucoma associated with anomalies. Glaucoma with aniridia is seen in 50% of cases. Glaucoma with iridocorneal dysgenesis, that is seen in that is there is posterior embryotoxin. Which is characterized by this prominent Shaw-based line. It is there. It is the associated anomaly is Axenfeld anomaly, Rieger anomaly, and Peters anomaly. I have done a video in anterior segment dysgenesis. I will put the link in description box. If you are interested, you can watch that in about posterior embryotoxin. This is these are the then next is glaucoma associated with ectopia lendis. That is associated. It is usually seen in Marfan syndrome, Weil-Marchesani syndrome, and homocystinuria. Next is glaucoma associated with phacomatoses. It is seen in Sturge-Weber syndrome, neurofibromatosis, von Recklinghausen's neurofibromatosis. Next associated anomaly is Lowy syndrome, that is oculocerebral renal syndrome. These are the glaucoma associated with anomalies. Next, we will move on to primary open angle glaucoma. Primary open angle glaucoma, it is a chronic simple glaucoma of adult onset. Okay. Characteristic features is it is a slowly progressive with increased IOP. Then on gonioscopy, it will be angle will be open normal appearing angle of anterior chamber. Angle of anterior chamber will be open normal appearing. Characteristic of optic disc cupping will be there. Optic disc changes will be there. Then visual field, specific visual field defects will be there. Now risk factors: hereditary, old age, myopes, black race myopes, diabetics, and cigarette smoking. Prevalence is 1 in 100 in general population more than 40 years. So whenever elderly patient comes to OPD, we do IOP checkup because they are at more risk of developing glaucoma. Pathogenesis, it is due to decreased aqueous outflow because of increased resistance. Decreased outflow due to increased resistance. Now resistance can be due to thickening and sclerosis. See, this is the trabecular meshwork. Trabecular outflow, they have this intertrabecular spaces. So thickening and sclerosis of the trabecular meshwork or narrowing of the intertrabecular spaces, then deposition of amorphous material in the juxtacanalicular space, collapse of the Schlemm's canal, and absence of giant vacuoles in the cells lining it. Thickening and sclerosis of the trabecular meshwork, narrowing of the intertrabecular spaces, deposition of the amorphous material. This trabecular meshwork is something like this sieve like structure. So thickening and sclerosis and narrowing of the intertrabecular spaces and deposition of amorphous material. Now collapse of Schlemm's canal and absence of giant vacuole. See, this is the Schlemm's canal. Of course goes through the Schlemm's canal through the collector channel. This Schlemm's canal is lined by these giant vacuoles. So the absence of giant vacuoles in the cells lining it can also lead to the to increased resistance to outflow. Now clinical features includes headache, eye ache. Then patient can complain of difficulty in reading and close work. This can be due to accommodation failure as a result of constant pressure on the ciliary muscle, which leads to frequent change of presbyopic glasses. Here, because of the constant pressure on the ciliary muscles, the patient can have accommodative failure. So the patient will complain of reading and difficulty in reading and close work, and then there will be frequent changes of presbyopic glasses. Then there will be delayed dark adaptation. Anterior segment signs on slit lamp, usually in the initial slit lamp examination, in the initial stage it will be normal. In later stages there will be sluggish pupillary reflex, hazy cornea. Then central corneal anterior segment, central corneal thickness less than 555 micrometers is a significant risk factor for POAG. Intraocular pressure changes. Now exaggeration of normal, normally there will be diurnal variation, but exaggeration of normal diurnal variation of IOP can be seen. IOP falls in the evening, usually IOP decreases in the evening, that is normal, whereas in case of POAG it increases during evening. Now a variation of IOP of more than 5 mm is suspicious and more than 8 mm mercury is diagnostic. In later stages, IOP is permanently raised more than 21, that is it ranges between 30 to 40 millimeters of mercury. Now optic disc changes. Confocal scanning laser topography, that is Heidelberg retinal tomography, is an accurate and sensitive method for recording and documentation of optic disc changes. This is a report of a confocal scanning laser topography. This is the most accurate and sensitive method for demonstrating optic disc changes. Now in early glaucomatous changes, include vertically oval cup due to selective. This is the optic disc, this is the neural cup, this is the disc, this is the neural retinal rim. So due to the selective loss of neural retinal tissue in the superior and inferior poles, there will be a vertically oval cup. Then asymmetry of the cup, that is more than 0.2 difference. A large cup more than 0.6, normal cup disc ratio is 0.3. Then splinter hemorrhages, pallor areas will be present. Then atrophy of nerve fiber layer. See, this is atrophy. Here you can see the atrophy of the retinal nerve fiber layer. See here, it is best seen in red free filters. Here atrophy of retinal nerve fiber layer can be seen. So this here is a diagram of the fundus. Large cup disc ratio more than 0.6, vertically oval cup, nasal shifting of the retinal vessels can be seen, and splinter hemorrhages of optic disc. This again is a optic disc hemorrhage. Wedge shaped defect can be seen here. Wedge shaped defect. Now in case of advanced stages, advanced glaucomatous changes include mark cupping, that is 0.7 to 0.9, thinning of neural retinal rim, notching of rim, especially disc margin is pathognomic. Especially disc margin. Then nasal shifting of vessel, retinal vessel, which we saw, it is known as bayoneting sign. Pulsation of the retinal arterioles, that is pathognomic sign of glaucoma. And lamellar dot sign can be seen due to the thinning. Lamellar dot sign and total pallor of disc and total bean pot cupping can also be seen in advanced stages. Here we can see the lamellar dot sign, then nasalization of retinal vessels and complete loss of neuroretinal rim can be seen. Later on, the patient it will progress to glaucomatous optic atrophy. We can see the pale optic disc here. That is the final stage. Then next coming to visual field defects. Visual field defect appear only after 40% of the axons have been damaged. Only then the defect visual field defects start to appear. Now arcuate fiber, these are the retinal fibers. Here superior radiating fibers and inferior radiating fibers in the nasal area, and superior arcuate fibers and inferior arcuate fibers are present in the temporal area, and these are the papillomacular bundle fibers. Now the arcuate fibers here, these are the arcuate fibers. These arcuate fibers occupying the superior and inferior temporal regions are more sensitive to glaucomatous change accounting to the early loss in that fields. Okay, arcuate fibers are more sensitive. Now macular fibers are most resistant. This is hence the central vision is retained. Now visual field defects are initially observed in germs area. Okay, initially observed in the germs area. Isopter contraction is earliest but of limited diagnostic value. It is the earliest, but it is of limited diagnostic value. It can also be seen in other conditions. Then bearing of blind spot is also non-specific. Then initially there is a small wing-shaped paracentral scotoma. Here this is a paracentral scotoma. Here this is a paracentral scotoma. Paracentral scotoma is the earliest clinical significant of field defects. Okay, then comes the seedal scotoma, that is a sickle shaped scotoma, sickle shaped. Then we have the arcuate and germ scotoma here. This is a paracentral scotoma. When paracentral scotoma binds with the blind spot, we get the seedal scotoma. It extends to the entire superior zone. Then we have the arcuate germ scotoma. Then we have the double arcuate both in superior and inferior quadrant. Then we have Roney's nasal step. And Roney's then we have tubular vision, only the temporal island field of vision. Tubular vision is seen in case of advanced stages. Temporal island vision is more resistant and it is lost in the end. Okay. This again here is a first we will see this is a blind spot enlargement, then blind spot, this is a blind spot, then paracentral scotoma, arcuate. This is a paracentral, then germ scotoma, arcuate scotoma. This is a nasal step. This is the nasal step here. Then central scotoma and centrocecal scotoma. Central scotoma. These are the visual field defects. Now coming to investigations, applanation tonometry is gold standard and this is preferred over Schwartz tonometer. Measurement of central corneal thickness is to be done. Diurnal variation test should be done, gonioscopy should be done, perimetry to detect visual field defects should be done. Static perimetry is a dynamic Goldman perimetry is a which is not commonly used. This is not commonly, static is preferred now. And actually standard automated perimetry, that is Humphrey field analyzer, is widely used now. This is widely used. Standard automated perimetry, Humphrey field analyzer. Coming to nerve fiber layer analyzer to detect glaucomatous damage to retinal nerve fibers before the appearance of visual field defect. Before visual field defect, we can see only after 40% loss of the ganglion cell loss. So, in order to detect glaucomatous damage to retinal nerve fibers before the appearance of visual field defect, we use nerve fiber layer analysis. Now, diagnosis of POAG. POAG is defined as increased raised IOP more than 21 mm mercury. There will be optic disc cupping and visual field changes will be there. Ocular hypertension is when there is IOP is more than 21 mm mercury, but no optic disc or visual field changes. Normal tension glaucoma or low tension glaucoma is when there is glaucomatous optic disc cupping with or without visual field changes, but with associated IOP which is consistently normal. Like the IOP will be normal or it will be lesser than 21 mm, and there will be optic disc changes and with or without visual field changes. Treatment. Now, medical management is a primary option. Primary option in primary open angle glaucoma. First, we will discuss about prostaglandin analogs. Prostaglandin analogs is the first choice, but it is a little pricey, so it is the first choice in affordable patients. Major mechanism is it increases uvoscleral outflow. Other mechanism is sometimes it also increases in some drugs also increases trabecular outflow, but main mechanism of action is increases uvoscleral outflow. Then administration is once every day at bedtime is generally recommended. Okay, that is administration. Dose. Side effect is common, the most common and troublesome side effect is conjunctival hyperemia. That is why one reason why it is given at bedtime. Then eyelash, there will be eyelash thickening, lengthening and hyperpigmentation. Then there will be irreversible iris hyperpigmentation as will be also there, and reversible, this periocular skin and eyelid pigmentations are reversible. This is a typical prostaglandin associated periorbitopathy here. Now, the drugs are latanoprost, which is the first line drug. Latanoprost is the first line drug. Bimatoprost, it has greater IOP lowering effect than other prostaglandin analog, but there is relatively more conjunctival hyperemia and periorbital fat or loss will be there, but relatively less headache and iris hyperpigmentation. Other drugs are travoprost and trafaloprost. These are the drugs coming under prostaglandin analogs. Next we will discuss about beta blockers. Beta blockers is the first choice of drug in poor patients. Mechanism of action is decreased aqueous production. It should not be instilled at bedtime because it can decreases blood pressure. It can may cause a profound drop in blood pressure. Side effects include bronchospasm, hence it may be fatal in asthmatic patients or other reversible airway disease. It is critical, so it is critical to exclude a history of asthma before prescribing beta blocker. Then cardiovascular side effect include heart block, bradycardia, worsening of heart failure and hypotension. It is preferred over prostaglandin analogs in cases of ocular inflammation. Prostaglandin is usually not given in these conditions. So, beta blockers are preferred over these conditions. It is ocular inflammation, cystoid macular edema and history of herpes simplex virus, keratitis. Herpes simplex keratitis. Beta blockers are preferred. Now, first coming to the drugs, timolol malate. Timolol malate is a non-selective beta blocker. It is available in 0.25 and 0.5%. It is the most popular initial therapy, and there are two phenomena known as short-term escape phenomena and long-term drift phenomena. Short-term escape phenomena means marked initial fall in IOP, followed by transient rise with continued moderate fall in IOP. Marked initial fall in IOP followed by a transient rise with continued moderate fall in IOP. Okay, that is a short term escape phenomena. Long term drift phenomena means there is slow rise in IOP who are well controlled by many months of therapy. After many months of therapy, then there is a slight slow rise in IOP. That is long term drift phenomena. Next is betoxolol. It is a cardioselective. BB you can remember, it is a cardioselective beta blocker, beta 1 blocker. It the beta boxolol is it also can increase optic nerve blood flow, may also be increased, may be increased due to a calcium channel blocking effect, so that visual field preservation is superior in betoxolol, and there is less bronchoconstriction because it is selective beta blocker. Optic nerve blood flow may be increased due to a calcium channel blocking effect, so that the visual field preservation is superior. Then lisabonolol is non-selective, but it is long acting. LL you can remember, long acting. Cartilol is in patients with hyperlipidemias and atherosclerotic cardiovascular diseases. Cartilol, LL you can remember. Then metipronolol is linked with granulomatous anterior uveitis. Anterior uveitis. Next we will come to alpha agonist. Now see, beta agonist here acts by inhibiting the inhibiting the adenyl cyclase. Cyclic AMP is inhibited so the cyclic AMP enzyme is inhibited, and thus it decreases the aqueous production. Okay. Now alpha blockers also decreases aqueous synthesis. Alpha agonist is used, it also the active G1 adenyl cyclase is inhibited here, and again cyclic AMP is decreased in case of alpha agonist. Alpha agonist. It also decreases aqueous synthesis and increases uveicular outflow, that is alpha agonist. Now they cross the blood brain barrier. This alpha agonist can cross the blood brain barrier. So it should be used with great caution in young children in whom severe cerebral central nervous system depression and hypotension has been reported, as it can cross the blood brain barrier. Now it is contraindicated in children less than 2 years of age. It is contraindicated. Okay. Then there is dipivirfin. It acts on alpha 1, alpha 2, beta and beta 2. Then it is converted to epinephrine. This dipivirfin is converted to epinephrine after its absorption into the eye. Side effects include follicular conjunctivitis and hypertension. Side effect, follicular conjunctivitis and hypertension, that is dipivirfin. Next is brimonidine. It is a selective alpha 2 agonist. Allergic conjunctivitis is the commonest side effect. Onset may be delayed for up to 18 months, okay, after commencement of the therapy. Even after 18 months allergic conjunctivitis can be seen. Then granulomatous antiriuvetus is very rare and xerostomia can be seen in some patients. Apraglutide is alpha 1 and alpha 2 agonist. It is combined usually principally to prevent or treat an acute rise in IOP following laser surgery or any anterior segment. That is why apraglutide is used. Then side effects include burning sensation, reactive hyperemia of the conjunctiva, conjunctival pigmentation can be seen, and follicular conjunctivitis, allergic blepharoconjunctivitis, mydriasis in FAKs, dry mouth, fatigue, drowsiness. Generally it is not suitable for long term use. Next is topical carbonic anhydrase inhibitors. Carbonic anhydrase inhibits the aqueous production. May precipitate. It can also cause corneal decompensation in patients with corneal endothelial dysfunction. Then relatively contraindicated in patients with sulfa allergy, sulfonamide antibiotics, sulfonamide allergy. Now dorzolamide is there. It causes a stinging and transient bitter sensation, taste following administration. Then there is allergic blepharoconjunctivitis can also be seen in some patients. Brinzolamide is of lower incidence of stinging and local allergy compared to dorzolamide, lower incidence. Next we will discuss about parasympathomimetic drugs, that is miotics. They are now predominantly used in the treatment of angle closure glaucoma. Miotics, the angle closure predominantly used in the treatment of angle closure. It reduces IOP by contraction of the ciliary muscle, which increases the facility of the trabecular outflow of aqueous. Pilocarpine is not preferred in young patient as it may cause spiosis and spasm of accommodation. Young it is not preferred because of the contraction of the ciliary muscles. Then it is also contraindicated in uveitis patient. Carbachol is an alternative to pilocarpine. Next coming to osmotic agents, mannitol, glycerol, isosorbate are the osmotic agents. It lowers IOP, it decreases IOP by creating an osmotic gradient so that water is drawn out from vitreous into blood. It is employed when a short term reduction in IOP is required that cannot be achieved by other means. Atropine, then coming to atropine, is contraindicated in glaucoma. Okay, atropine is contraindicated in glaucoma. Now coming to laser trabeculoplasty, here argon or diode laser trabeculoplasty is usually done. It is an additive effective medical therapy. It increases outflow by, see here we give laser spots laser spots are created here in laser trabeculoplasty. It increases the outflow facility by collagen shrinkage on the inner aspect of the trabecular meshwork and opening the intertrabecular spaces. It increases the outflow. Then selective laser trabeculoplasty. The selective laser trabeculoplasty, it targets selectively the pigmented trabecular meshwork. Here, this is iris ciliary body, posterior trabecular meshwork, that is the pigmented trabecular meshwork is targeted without causing damage to the non-pigmented cells or other structures, only to the pigmented trabecular meshwork, that is selective trabeculoplasty. Then surgery, it usually done as trabeculectomy, which is most frequently performed filtration surgery. It's a filtration surgery, fistulizing surgery for primary open angle glaucoma. Now, primary angle closure glaucoma, primary angle closure disease, it is a now it is a apposition of iris against the trabecular meshwork. Here you can see the apposition of iris against the trabecular meshwork here, resulting in obstruction of aqueous outflow by closure of an already narrow angle of the anterior chamber. There is no other ocular and systemic abnormalities, that is primary angle closure disease, no other ocular or systemic abnormalities. Now coming to primary angle closure glaucoma, there is a closure of angle plus optic disc changes plus visual field defects, that is primary angle closure glaucoma. Now the ratio, for every 10 occludable angle, that is primary angle closure suspects, there is only one case of primary angle closure glaucoma. In chronic primary angle closure suspect, angle closure glaucoma, same asymptomatic is more common than acute. 3:1 ratio is there. Now ratio of POAG to PACG is about 1:1. In Indians it is 1:1, then Chinese it is 1:2, and European Africans it is 5:1. That is a ratio of POAG is to PACG. Coming to risk factors, age is usually seen in 6 to 7 decade. Male is to female ratio is 1:3. Hypermetropic eye with shallow AC. Patient will have a hypermetropic eye with shallow AC. And eyes in which it is usually seen in eyes in which there is iris lens diaphragm is placed anteriorly. There is plateau iris configuration. These are the predisposing factors. Okay, when iris lens diaphragm is placed anteriorly, or when there is plateau iris configuration. Here there is a plateau iris configuration, and eyes with narrow angle. Here they have done a PI for plateau iris configuration. This is a plateau iris configuration, and in eyes with narrow anterior chamber angle, this narrow angle of anterior chamber can be due to small eyeball or large lens, or smaller corneal diameter, bigger ciliary body, more anterior insertion of the iris into the ciliary body, onto the ciliary body. These are the predisposing factors. Now coming to mechanism of rise in IOP, there can be a pupillary block mechanism, or plateau iris configuration and syndrome, or because of phacomorphic mechanism. Pupillary block mechanism can be because of physiological mydriasis, that is reading in dim illumination, watching cinema or TV in a dark room, anxiety, emotional stress, or it can be pharmacological mydriasis can be there. Then plateau iris configuration and syndrome, usually there is normal anterior chamber depth in these cases. Anterior chamber depth will be normal, but there is a flat iris plane, and here the iris plane will be plateau iris, the iris plane is flat, and minimal pupillary block, that is angle closure glaucoma without a pupillary block, will be without pupillary block. We have seen in plateau iris configuration and syndrome. Iridotomy is sufficient in these patients. Here we can do iridotomy. In plateau iris we can do iridotomy to control IOP in such patients. Next is phacomorphic mechanism. Phacomorphic is abnormal lens may cause, here there is a phacomorphic abnormal lens may cause pupillary block or push the peripheral iris towards the angle structure, thus causing glaucoma. Now classification, it can be either primary angle closure suspect, or primary angle closure, or primary angle closure glaucoma. It can be divided into these three. Now first we will come to primary angle closure suspect. It is a asymptomatic stage. asymptomatic stage. There is eclipse sign because of the decreased anterior chamber, because of the iris shadow here. If you give in torchlight examination, this is diffused, like throughout it is illuminated because of the anterior chamber decrease in the anterior chamber depth, because we can see this eclipse sign in torchlight illumination because of decrease in axial anterior chamber depth. This can be seen in primary angle closure suspect. There is no symptoms. Then on slit lamp examination, we can say decrease anterior chamber depth, convex shaped iris lens diaphragm. Here there is convex shaped iris lens diaphragm, and close proximity of the iris to the cornea can be seen. Close proximity of the iris to the cornea in the periphery. Now we can use a Van Herrick slit lamp grading. Van Herrick slit lamp grading of the angle. Here we compare the corneal thickness. See, this is the corneal thickness here. This one is the corneal thickness. Corneal thickness to the peripheral anterior chamber depth. This is the peripheral anterior chamber depth. Yeah, this is the slit lamp picture. This is the corneal thickness. This is the corneal thickness, and this is the peripheral anterior chamber depth. This part is the peripheral anterior chamber. Optical black space is the peripheral anterior chamber depth, and this is the iris illumination. Now grading based on Van Herrick slit lamp grading. In grade 4, if the peripheral anterior chamber depth is 3/4 of corneal thickness, then it is known as grade 4. It is a wide open angle. Grade 3 is peripheral anterior chamber depth is 1/4 to half of corneal thickness. Grade 2 is 1/4 of corneal thickness, and grade 1 is less than 1/4 of corneal thickness. That is extremely narrow angle. That is Van Herrick grading of slit lamp grading of the angle of anterior chamber. Now coming to diagnostic criteria of primary angle closure suspect. Now primary angle closure gonioscopy should reveal a iridotrabecular contact in greater than 270° angle, and there should be no peripheral anterior synechia. That is iridotrabecular contact. Contact should be more than 270°, and but IOP will be normal, and IOP should be normal, and optic disc there is no glaucomatous changes, and visual fields defect is also not there. IOP is normal, optic disc and visual field is also normal. That is primary angle closure suspect. In primary angle closure suspect, we do a prophylactic peripheral iridotomy. There is angle closure, we do laser and we create a hole here, that is peripheral iridotomy, so that aqueous can pass through the hole. Then this is a peripheral iridotomy. If significant iridotrabecular contact persists after iridectomy, then we do a iridoplasty. This is iridoplasty. Iridoplasty or long term pilocarpine prophylaxis can be given. That is primary angle closure suspect. Now coming to primary angle closure. The defining criteria for primary angle closure is the iridotrabecular contact noted on gonioscopy is greater than 270° angle. Then IOP is elevated or primary peripheral anterior synechia is present, but optic disc and visual field is normal. This is the peripheral anterior synechia in gonioscopy, and iridotrabecular contact should be greater than 270°. It can manifest as subacute, or acute primary angle closure. Subacute primary angle closure. When there is transient increase in IOP, that is 40 to 50 millimeters mercury, lasting for about 2 minutes to few minutes to 2 hours. It is precipitated by mydriasis, physiological mydriasis, pharmacological mydriasis, or physiological shallowing of AC after lying in prone position. Patient will have transient episode of blurring of vision, colored halos and headache. Then it is a self-terminating attack, occurs due to physiological meiosis. Eye is not congested in subacute. Then colored halos in peripheral primary angle closures due to accumulation of fluid in the cornea, and alteration of refractive condition of the corneal lamellae, that is a cause of a colored halos. Primary angle closure. Colored halos due to primary angle closure in cataract can be differentiated by Emsley's Fincham's synovic slit. In acute primary angle closure, next is acute primary angle closure. Here there is acute rise in IOP with primary angle closure that occurs due to pupillary block. to pupillary plaque. This does not terminate on its own and it is a sight-threatening emergency. Symptoms include pain in the eye, nausea, vomiting, then rapidly progressing impairment of vision. It is accompanied by redness. Here you can see redness. Patient will have photophobia, lacrimation, and patient can have a previous history of intermittent attack. Conjunctiva in acute primary angle closure glaucoma, the signs include in conjunctiva we can see it will be chemosed and congested. It will be congested and chemosed. Congestion will be present in severe cases. Then cornea will be edematous. Anterior chamber will be shallow, become very shallow, and aqueous flare will be present. Angle of anterior chamber will be completely closed and iris will be discolored. Pupil will be semi-dilated, vertically oval and fixed pupil, then not reacting to light and accommodation. IOP will be markedly elevated, like up to 40 to 70 millimeters mercury. Optic disc will become edematous and hyperemic. Immediate medical therapy to lower IOP includes systemic carbonic anhydrase inhibitors, that is IV acetazolamide can be given. A single dose each of epaclonidine 0.5% or 1%, timolol 0.5%, prednisolone 1%, dexamethasone 0.1% to the affected eye, leaving 5 minutes each between each can be given. Pilocarpine 2 to 4%, 1 drop to the affected eye repeated half an hour, and systemic hyperosmotics IV mannitol oral glycerol can be given. Definitive therapy is laser peripheral iridotomy as soon as the cornea becomes clear is done. Then laser iridotomy preferred over surgical iridotomy is preferred over surgical iridotomy. Then filtration surgery, trabeculectomy, when peripheral iridotomy is not effective, filtration surgery can be done, trabeculectomy. The clear lens phacoemulsification, clear lens extraction by phacoemulsification with IOL implantation in presence of cataract can be done. Prophylaxis in normal eye, prophylactic laser iridotomy is done as soon as possible. As early as possible it is done in prophylactically in the other eye. Sequelae of acute primary angle closure is sometimes there can be very rarely spontaneous angle opening can occur very rarely. Then other complications include ciliary body shutdown, that is this ciliary body temporary cessation of the ciliary body will occur. Because then there will be temporary cessation of the aqueous humor secretion due to ischemic changes in the ciliary epithelium. Due to ischemic changes, clinical functions will be similar to primary angle closure, but there will be reduced IOP, very low IOP, and markedly reduced pain will be there. Other features will be similar to primary angle closure in ciliary body shutdown. Other sequelae of acute primary angle closure is Voges triad. See, Voges triad is seen in both treated and untreated patient. It is characterized by glaucoma flecken, patches of iris atrophy, and slightly dilated non-reacting pupil. Glaucoma flecken is anterior subcapsular lenticular opacity, and iris atrophy, patches of iris atrophy. Here you can see glaucoma flecken, Voges triad glaucoma flecken, patches of iris atrophies can be seen, and this slightly dilated oval non-reacting pupil due to sphincter atrophy can be seen. That is Voges triad. Now next is primary angle closure glaucoma. Primary angle closure glaucoma, the defining criteria for primary angle closure glaucoma is iridotrabecular contact on gonioscopy should be more than 270-degree angle. Then IOP should be elevated. Primary peripheral anterior synechiae should be present. Optic disc should have glaucomatous damage. Visual field defect shows characteristic glaucomatous defect. Clinical features is similar to POAG except for narrow angle. There will be constantly elevated IOP, no congestion, but the eyeball remains wide, there is no congestion, it is painless. Optic disc, there will be glaucomatous cupping. Visual field defects is similar to POAG. Gonioscopy reveals more than 270 degrees angle peripheral anterior synecdoche. Gonioscopy findings provide the only differentiation between the primary angle closure glaucoma and primary open angle glaucoma. Treatment is laser iridotomy, trabeculotomy, prophylactic laser iridotomy in the fellow eye also should be done. Now, absolute primary angle closure glaucoma, that is absolute glaucoma. It is a untreated primary angle closure glaucoma that progresses finally to this phase. It is a painful blind eye. The patient can have perilimbal reddish hue due to dilated anterior ciliary veins. Then caput medusa will be there due to few prominent enlargement of enlarged vessels in long standing cases. In early cases, cornea will be clear and insensitive. Later there can be bullous keratopathy or filamentary keratitis. Bullous keratopathy will be there. And AC will be very shallow. AC is shallow, and atrophic iris with fixed dilated pupil can be seen. High IOP lead to stony hard eyeball. On digital tonometry we can feel a stony hard eyeball. Management of absolute glaucoma is retrobulbar alcohol injection for pain relief or destruction of the secretory epithelium, that is cyclocryotherapy, cyclodiathermy, cyclophotocoagulation. This here shows the cyclocryotherapy. We destruction, the ciliary epithelium is destroyed. Finally, if there is no relief, we can go for enucleation of eyeball. Next is secondary glaucoma. Other types of glaucoma. Secondary glaucoma is can be trabecular. It can be either pre-trabecular, trabecular or post-trabecular. See, pre-trabecular is when the aqueous outflow is obstructed by a membrane over the trabecula. Okay, that is pre-trabecular. It can be either due to fibrovascular tissue seen in neovascular glaucoma, or due to membranous endothelial cellular membranous proliferation seen in iridocorneal endothelial syndrome, or epithelial cellular migration, membranous proliferation like epithelial, because of epithelial ingrowth there can be epithelial ingrowth. There can be pre-trabecular obstruction, that is aqueous outflow is obstructed by a membrane covering the trabecula. Trabecular obstruction occurs as a result of clogging up of the trabecular meshwork. That it can be because of pigment particle, then it is known as pigmentary glaucoma. Because of pseudo exfoliation, then pseudo exfoliative material, then or else it can be because of RBCs, then it is known as red cell glaucoma. Then or due to degenerated red cells, then it is known as ghost cell glaucoma. Macrophages can be and lens particles can be there, then it can be because of phacolytic. Macrophages and lens particle can lead to phacolytic glaucoma. Then alteration of the trabecular fibers themselves by edema, because of trabeculitis in case of hypertensive uveitis can be there. Then scarring can be there, seen in post traumatic angle recession. Post trabecular, here aqueous outflow is impaired due to elevated episclenar venous pressure, that is post trabecular because of carotidocavernous fistula, Sturge-Weber syndrome or obstruction of the superior vena cava can cause post trabecular. Next is secondary angle closure glaucoma with pupillary block and without pupillary block. Closure glaucoma without pupillary block, it can be, there can be seclusia pupillae. Seclusia pupillae is 360 degree posterior synecdoche will be there. Usually secondary to recurrent iridocyclitis. There can be phacomorphic glaucoma. These are the causes with pupil. Okay, phacomorphic glaucoma, subluxated lens, subluxated lens, phacomorphic glaucoma. See, so these are with pupillary block, seclusia pupillae, 360 degree synecdoche, usually secondary to recurrent iridocyclitis, subluxated lens, phacomorphic glaucoma. Capsular block syndrome will be there. There is something called capsular block syndrome. with 360-degree closure, iris capsule adhesion in pseudophakic eye. It is iris and capsule adhesion in pseudophakic eye, that is capsular block syndrome. Aphakic pupillary block, anterior chamber lens implant without a patent iridotomy. These can lead to pupillary block secondary angle closure glaucoma. Without pupillary block, in case of advanced neovascular glaucoma, then chronic anterior uveitis, cilio-choroidal effusion. Capsular block syndrome without iris capsule adhesions, ciliary body cyst or other ciliary body significant or posterior segment tumors, or proliferative retinopathy of prematurity, malignant glaucoma. These are the causes of without pupillary block. Next is lens induced or phacogenic glaucoma. It is lens induced secondary angle closure glaucoma. Lens induced secondary angle closure glaucoma. It can be phacomorphic. Phacomorphic is swollen lens in intumescent cataract. This is swollen lens. It is seen in phacomorphic is seen in intumescent cataract. Phacotopic is secondary angle closure. Phacotopic is anterior displacement of lens, due to anterior displacement of lens. Next is secondary open angle. Lens induced secondary open angle glaucoma can be because of phacolytic glaucoma, that is a lens protein glaucoma. Trabecular meshwork, here the trabecular meshwork is clogged by lens proteins, macrophages and inflammatory cells, that is phacolytic glaucoma. Then lens particle glaucoma, here again the trabecular meshwork is blocked by lens particle floating in AC. It is usually occurs after extracapsular cataract extraction or traumatic rupture of lens. Then secondary open angle glaucoma lens induced can be due to phacoanaphylactic or phacoantigenic glaucoma. Here acute inflammation due to antigen antibody reaction can be seen. That is secondary angle closure and secondary open angle lens induced glaucoma, causes for secondary lens induced phacogenic glaucoma. Next we will go to pigmentary glaucoma. Now, pigmentary glaucoma is a secondary open angle glaucoma. There is clogging of the trabecular meshwork by pigment particles. Meshwork is there is pigment particle deposition of the trabecular meshwork. Then 50% of the patients with pigment dispersion syndrome develop glaucoma. It occurs in young myopic males. Most common in young myopic male. Deposition of pigment granules in the anterior segment structures occurs. Pigment deposition on the corneal endothelium. See here, this pigment deposition on the corneal endothelium is known as Krukenberg spindle in the corneal endothelium. Then gonioscopic, we can see pigment deposition along Schwalbe's line. Here this pigment deposition along Schwalbe's line, especially inferiorly, this is known as Sempoli's line. Then because of the contact of the iris and the lens, there can be radial slit trans-like illumination. See this radial slit. See iris trans illumination in trans illumination defects in the mid periphery will be seen. This is because here iris in a normal case, the iris is in here iris is in contact with the with movement of iris, it is in contact with the lens. So there will be when there is movement during there is meiosis and mydriasis, there is movement of the iris, there will be pigment due to the rubbing of the iris in the lens, the pigment will be dispersed, which will later lead on to transillumination defect in slit lamp examination. That is, iris transillumination defect will be in the mid peripheral region in case of pigmentary glaucoma. Next is neovascular glaucoma. Neovascular glaucoma is usually associated with neovascularization of the iris. Okay, there is here we can see neovascularization here. Neovascularization of the iris can be seen, which is seen in proliferative diabetic retinopathy, central vein occlusions, sickle cell retinopathy and Eales disease. Next is glaucoma due to uveitis. It is a non-specific inflammatory glaucoma. It can be open angle inflammatory glaucoma or angle closure inflammatory glaucoma. Then specific, it can be either non-specific or specific. Specific, hypertensive, uveitis, specific hypertensive uveitic syndrome. It is usually seen in Fuchs uveitic syndrome and glaucomatocyclitic races. In Fuchs uveitic syndrome, glaucomatocyclitic crisis, we will see the patient will have secondary open angle glaucoma, there is increased IOP, and there is no congestion and all. The eye is white, known as white eyes. Okay, it's seen in Fuchs uveitis, glaucomatocyclitic crisis. Next is angle recession cleavage glaucoma. Angle recession glaucoma, it is a type of traumatic glaucoma. See, angle recession, it refers to the rupture of ciliary body face between the scleral spur and iris root. Here we can see on external force the longitudinal, the line oblique, this is a longitudinal muscle oblique and the circular muscle. There is a rupture of the ciliary body in case of trauma, refers to rupture, that is known as angle recession. Then it is unilateral. Open angle glaucoma occurs years, maybe can occur even years after blunt trauma. Angle recession is not the cause of glaucoma, just it indicates the old trauma, that's all. Okay. Here again the picture showing angle recession. There is rupture in the ciliary body, you can see here. This is again picture showing. Okay. Next is ciliary block glaucoma, that is malignant glaucoma or aqueous misdirection syndrome. It is a complication usually seen after any intraocular operation. Okay, any intraocular surgery, after any intraocular surgery we can see like cataract or any anterior segment surgeries. Classically occurs, even posterior segment surgeries also it can be seen. Classically occurs in patients with primary angle closure operated for peripheral iridectomy or filtration surgeries most of the time. Here normal flow of aqueous is blocked at the level of ciliary body and it is misdirected posteriorly into the vitreous. Vitreous volume increases, which eventually lead to pushing of the iris lens diaphragm forward. So there will be extremely shallow AC because of the pushing of the iris lens diaphragm forward, or flat AC in presence of patent iridectomy. It is actually suggestive of this aqueous misdirection syndrome. Even though there is a patent iridectomy in patients who have done iridectomy, but still the IOP will be high and the AC will be shallow in this patient, and there will be marked increase in IOP and negative serials test, and the patient is unresponsive to miotics. Medical treatment include atropine, phenylephrine, beta blocker, alpha adrenergic agonist and carbonic anhydrase inhibitors. If medical therapy fails, then we have to go for pars plana vitrectomy with or without lensectomy. YAG laser hyalodotomy for aphakic and pseudophakic patients can be done. Here we do a hyalodotomy here, and we done for aphakic and pseudophakic patients so that aqueous will be gone into the anterior chamber. Now glaucoma associated with intraocular hemorrhages. Next topic. Here red cell glaucoma, it is a fresh traumatic hyphemia, blockage of the in fresh traumatic, this fresh traumatic hyphemia causes blockage of the trabecular meshwork by RBCs. Hemolytic glaucoma, open angle glaucoma, due to clogging of trabecular meshwork caused by macrophages laden with lysed RBC debris. Gaussel glaucoma is secondary open angle glaucoma in aphakic or pseudophakic eyes after vitreous hemorrhages, usually after 2 weeks of vitreous hemorrhage. Then there is one more glaucoma known as hemosiderotic glaucoma. Next is glaucoma associated with iridocorneal endothelial syndrome, ICE syndrome. Here there can be, see, iridocorneal endothelial syndrome, ICE syndrome, there can be progressive iris atrophy, Chandler syndrome and Cogan-Reis syndrome. Progressive iris atrophy, it is there is marked correctopia, that is abnormally situated pupil here, correctopia, polyatrophy, and which can lead to hole formation. That is progressive iris atrophy. In Chandler syndrome, there is minimal iris changes, but there is marked corneal edema. In Chandler syndrome, you can remember. Then Cogan-Rees syndrome, there is nodular or diffuse pigmented lesions of the iris. That is iris-Nevi syndrome. Common features is to all of this is abnormal corneal endothelial cell. Endothelial cells proliferate to form endothelial membrane. So, if this is a show you. See, if this is the angle of anterior chamber, then this abnormal corneal endothelial cells proliferate to form endothelial membrane in the angle of anterior chamber. This is common, that is a common features to all these three syndrome. Here we can see iris atrophy leading to this leading to correctopia, atrophy then leading to hole formation. Here we can see Chandler syndrome causing corneal opacities, and then iris pigmentation can be seen in case of nodular diffuse pigmented lesions in case of Cogan-Rees syndrome. Now coming to last topic, summary of surgical procedures for glaucoma. First we will discuss about peripheral iridectomy. It is usually we create a laser, we create a hole in the iris. Here treatment, it is the treatment of all stages of primary angle closure glaucoma. It is, and also in prophylaxis, in as a prophylaxis in the fellow eye it is done. Next is goniotomy and trabeculotomy. For congenital and developmental glaucoma we do goniotomy. Here, this is a trabeculotome. Here we make incision here. This is a trabeculotome. Using trabeculotome we do trabeculotomy. This is the trabeculotome. Next is filtering operations. So for free filtering, like guarded this partial thickness fistula filtering, if PA, it is usually done if peripheral iridotomy fails, or if primary angle closure glaucoma with peripheral anterior segment, peripheral anterior sinus involving more than 270-degree angle, or if PI fails and medical treatment is also not responsive in primary angle closure glaucoma, or POAG, primary open angle glaucoma not controlled by medical treatment. Congenital and developmental glaucoma, if trabeculotomy and goniotomy fails, and secondary glaucoma where medical therapy fails, we do a filtering surgeries. That is, here we make a fistula from anterior chamber, the aqueous flows onto the subtenon space here. That is filtering surgery, or done in these cases. Then non-penetration filtration surgery is deep sclerectomy. We make a incision in sclera, or viscocanalostomy where we give viscous agents are inserted onto the trabecular meshwork. Then glaucoma drainage device. Next is glaucoma drainage. It allows aqueous outflow by creating a communication between the anterior chamber and the subtenon space. Same way, but here there is a we insert a device here so that there is more regulated outflow from anterior chamber into the subtenon space. It is designated to divert aqueous humor from anterior chamber to an external reservoir, where the fibrous capsule form about after this plate is adhered, and after 4 to 6 weeks this fibrous capsule will be formed and it will become adherent. Sure. Okay, from aqueous humor to the subtenon space. Indication is neovascular glaucoma, glaucoma with aniridia, intractable primary and secondary glaucomas, where even trabeculotomy with adjacent antimetabolic therapy fails. In those cases we give glaucoma drainage devices. Next is cyclodestructive procedure. It is usually done in cases of absolute glaucoma. It lower IOP by destroying the part of the secondary ciliary epithelium. The ciliary epithelium is destroyed, ciliary body is destroyed, which secretes aqueous humor. It is usually done in absolute glaucoma. Cyclodestructive procedure currently in use are cyclocryotherapy, NDIAC laser cyclodestruction, and diode laser cyclophotocoagulation. Next is triple procedure for glaucoma. That is, it includes trabeculotomy, extracapsular cataract extraction, and posterior chamber intraocular lens implantation. That's it.